So dear jury, dear audience, welcome to the one-year progress report. I am Balázs Dorony, and the title of my PhD is Stabilizing Options in Hip Arthroplasty. I am a PhD student and a resident at the Department of Orthopaedics at Semmelweis University. My supervisor is Miklos Szendrei, and my SMS is Alex Schulze-Wenning, and my statisticians are Anna Walter and Péter Mátrai. My vision is to improve the life quality of patients living with endoprosthesis through enhancing their range of motion, and my mission to achieve this vision is to clarify the indications for different endoprosthesis designs applying the available scientific data. I have three ongoing projects. The first is the investigation of these different endoprosthesis designs. The second will be the investigation of patients who underwent revision hip arthroplasty at Semmelweis University. And the third will be the investigation of these endoprosthesis designs using the finite element method. So let me tell you about my first project. I started it in December 2022. So, what is an arthroplasty? To put it simply, it's a surgical procedure to replace a joint with an artificial joint. The two most common types of the arthroplasties are the hip arthroplasty and the knee arthroplasty. On the bottom below, you can see different endoprosthesis designs for the hip replacement. So the hip replacement is the surgery of the century, some people say. But why do they say this? Well, because the lifetime prevalence of hip osteoarthritis is 10 to 15%, which is the main indication for a hip replacement. Therefore, surgeons perform more than 1 million hip arthroplasties each year. That's a huge number. That's why the annual cost burden in the United States is around $15 billion, and it's still growing. And if a complication comes, a revision surgery will be necessary. But revisions are not without complications either. The most common complications of revision hip arthroplasties are the aseptic loosening, periprosthetic fractures, dislocations, and infections. Well, in an average center, around 20% of all replacement surgeries are revision surgeries, but according to some projections, this number will double by 2026. As these surgeries are complex and expensive surgeries, we would like to avoid their complications as much as possible. On the pictures here, you can see situations where something went wrong. On the top, from left to right, you can see a dislocation, periprosthetic fracture, and an aseptic loosening, and on the bottom you can see the end result of different revisions. So after a revision, our greatest concern is the chance of a dislocation happening. Let me tell you some options to prevent that. Our first option is to use a dual mobility design. This is an acetabular cup system. It has 2 points of articulation, an external and an internal one. It has increased range of motion, and it is designed to prevent dislocations, and it is used in primary and revision cases as well. Our next option is to use a constrained liner. This is, most of the time, it's a polyethylene liner applied in the acetabular cup. It is designed originally for recurrent instability or recurrent dislocations. It is holding the femoral head captive within the socket, and it usually uses a locking ring mechanism. It can be used in primary and revision cases as well. And our third option is to use a large femoral head. It is basically just a femoral head, but it's bigger than the so-called normal ones that we use most of the time. It means that the diameter of the head is 36 millimeters or more. It offers great impingement-free range of motion, and it increases the jump distance required for a dislocation. It affords more stability, although it results in more component wear and a higher risk of liner fracture. And the aim of our study is to find out which prosthesis design is the best to use in revision hip arthroplasties. Our clinical question is which acetabular cup design decreases the dislocation rate the most in revision hip arthroplasties. Our population is adults who underwent revision hip arthroplasty, and our interventions are the dual mobility design, the constrained liner, and the large femoral head, and our control is the standard acetabular cup. And the outcomes of interest are the dislocation rate, the aseptic loosening, and the overall implant survival. And their hypothesis is that these newer designs, the interventions, are superior compared to the standard acetabular cup in case of dislocations. The clinical implication of our study is the decrease in dislocation rates after revision arthroplasties and the potential lowering of hospital costs. Here you can see we performed a systematic search with the mentioned search key. And on the next slide you can see the flowchart of our selection process. We ended up with 56 eligible articles. And here you can see the state of the project. We are currently at the phase of planning and executing the statistical analysis. And these are the outcome measures that we are analyzing. The three mains are the comparison of dislocation rates between these different designs and the aseptic loosening rate and the overall implant survivalship. We are planning to perform the analysis of the baseline and surgical characteristics to be able to divide the populations into subgroups so we can perform subgroup analysis. And we are hoping that these results will give some explanations for the results of the investigation of the three main outcome measures. Well, what are the plans for the future? You heard that this is one project, but we are investigating 4 different designs, which means that we have 6 possible investigations or comparisons per outcome, and we have 3 outcomes. So that means the projected possible number of forest plots could be well over 10. And since we're not planning to write a book, but we are planning to write journal articles, my plan is to divide et impera, or divide and conquer, which means that after the analysis is complete, I'm planning to explore our options to subdivide this one project into maybe 2 to 4 smaller ones, so we can write articles that are actually comprehensive and understandable for the readers, and it makes sense for the scientific community. And the task for the upcoming weeks will be to present this idea to my team and to discuss it thoroughly. My second project is the investigation of patients who underwent hip revision surgery at the Hungarian Surgical Center. To be more precise, this is the orthopedic department of Semmelweis University. The pros of this project is that the orthopedic department of Semmelweis is one of the biggest surgical revision centers of Hungary. So they have extensive clinical knowledge and they have a diverse patient pool because it's a national institute. And their aim is to analyze the patients who underwent hip revision surgery there, or to be more precise, hip revision arthroplasties. But the data is collected by 2 PhD students, and the data is validated by 1 doctor, and we only contacted 1 center since it's a 1-center study. The data is already collected basically, and we are planning to perform the statistical analysis after we finish the first project. The inclusion criteria is adults who underwent hip revision arthroplasty at Semmelweis University, and our exclusion criteria are tumors as the indication for the primary or the revision surgery, and we are excluding 1 surgery with patients who had planned 2-stage revision for periprosthetic infections. So the 2 surgeries will be counted as 1. Let me tell you about my third project. It will be the analysis of these different endoprosthesis designs that we discussed using the finite element method. So what is this method, you may ask? The finite element method is a method for solving differential equations in engineering and modeling. To solve a problem, this method subdivides a larger system into small, simpler parts, and you can model these simple parts with much more simpler equations. These simple parts are called the finite elements. And after subdividing it and modeling it with simpler equations, we are assembling the finite elements and the simpler equations into larger systems with much more simple equations, and the end result will be that we will be able to conduct biomechanical analysis about these different hip prosthesis designs. So, what are the pros? we can model these different designs for different indications and demographics, and we can conduct analysis of these designs. We can structure the models based on fresh and comprehensive studies, which will be coming out later this year. And to the best of my knowledge, this will be the first finite element analysis conducted in this country in this topic. So let me summarize my projects. The first is the investigation of different hip endoprosthesis designs in revision hip arthroplasties. The second will be the investigation of patients who underwent revision hip surgery in a Hungarian surgical center. And the third is the investigation of these different designs that we mentioned before in the first two projects using the finite element method. The planned completion dates are September of 2023 and May of 2024 respectively. And let me close my presentation with the words of Senku Ishigami: "Science is only a word, painful is what describes it well." Thank you.
I would like to ask you about the one of your outcomes, which is aseptic loosening. How will you define it, and what imaging methods will you use for characterizing this outcome?
Well, thank you for the question. It's an excellent question. Well, aseptic loosening is most of the time characterized by the loosening of the components of the hip arthroplasty, which is shown most of the time on X-rays. So most of the time an AP and the lateral view in X-ray is enough for the diagnosis for the aseptic loosening, and it is shown by a radiolucency on the X-ray. Most of the time it is more than 2 millimeters. I mean the line of the radiolucency next to the implant. And the other important part is that the implant is not septic, and that's why it is called aseptic. So we don't have anything to prove that it could be septic. So no labor, and no imaging that would indicate a septic complication. And most of the time it is characterized by either the radiolucency or osteolysis. Yeah, thank you.
Good morning. I'm a little worried about your first project because that's about nowhere. I mean, so you showed a lot of background and then rationale, and then at the end you said that you are redesigning actually and cutting that to smaller pieces or so. So do you really think that you will send an article by September, which is the next 30 days? Thing one. Thing two, that I assume that you have already registered in Prospero. Huh? So what is happening now? Because if you want to change the design, I mean, you have to deal with in that side too. And then again, what is the realistic deadline for this?
Well, if you are asking if I believe, then yes, I believe. Yeah, to be simple. Of course, this plan that I mentioned can bring up some difficult questions for the future, and of course it can change the expected completion date of the project. Yeah, sure.
Also, I can add that, I mean, most studies actually have the level of 10 forest plots or more, so that should not be a problem because you can put those data in supplementary materials, and it happens with most papers actually. So it is not a major problem. I mean, there could be some others, but this is not a problem at all, even with high-level journals which have restrictions on the number of figures.
Thank you. And as I mentioned before, this is an idea now, so we have to discuss it with the team first. I just wanted to mention it because that's what I'm visioning for the project in the future. And the second thing is that, of course, I can put these forest plots in the supplementary materials. That could be one option. But what I'm thinking is that those forest plots would deserve to be their own journal article and not a supplementary material. That was the idea.